Hello, my name's Michael Hofman from the Peter MacCallum Cancer Centre in Melbourne, Australia, and it's my absolute pleasure to present to you today at the Canadian Association of Nuclear Medicine meeting on PSMA therapy. Here are some of my conflicts of interest and support. Now, when I heard I was going to be invited to the Canadian Nuclear Medicine meeting, I got very excited. I had dreams about coming back to Banff and doing some really cool hiking. And then COVID-19 didn't stop and it morphed into another virtual meeting. I was hoping to catch up with some old friends, some of whom are now on your board. Old fat Jonathan, Andrew, really disappointed that I can't catch up with all of you in person. Now, PSMA therapy it's morphed from PSMA imaging. So we're going to start the story by talking about PSMA imaging and focus mainly on therapy. The first small animal imaging was performed only 10 years ago, in 2012, published by the University of Heidelberg group in Germany. And 1 year later, the same group publishing these quite astounding first-in-human images, where we could see uptake in sub-centimetre disease. Here, a pre-sacral node measuring maybe 2 or 3 millimetres in size with extraordinary uptake. Now, at Peter Mac, we have been using gallium dotatate and lutetium dotatate for quite a number of years, so it was easy for us to use existing infrastructure, radiopharmacy, radiochemistry expertise to commence a PSMA therapy program. And we did our first PSMA PET in 2014. You can see patient number 1 right there. This patient had a high Gleason score tumour and was due to have a prostatectomy, but the PSMA PET revealed a sub-centimetre nodal metastasis in the right side of the pelvis and also this bone metastasis. And his management, patient number 1, was changed from curative intent surgery to hormone treatment. Now, when you do patient number 1 and you see such striking management impact, you know you're onto something really big. But I've also learned in my experience in nuclear medicine that although we accept these images as practice changing, our referring partners, clinicians, do not. They demand randomized controlled data. So we conducted the Pro-PSMA study. This was a 300 patient study conducted at 11 sites around Australia, led by Peter Mac, where we randomized patients with newly diagnosed prostate cancer scheduled to undergo curative intent surgery or radiotherapy to either a PSMA PET or a CT bone scan. And in this study, published in The Lancet last year, we showed superior accuracy, 92% compared to 65%, higher management impact, 28% compared to 15%, and fewer uncertain findings, only 7% compared to 23% for CT bone scan. And this trial is now changing practice in Australia, with PSMA PET really being a standard of care for staging men with newly diagnosed prostate cancer. We also embedded a health economics assessment in the study, and we showed that a PSMA PET actually is cheaper. PSMA PET costing around 1,200 Australian dollars compared to $1,400 for 2 tests, a CT and a bone scan with SPECT CT. So we could save $200 per scan per patient. And we're hoping to have national funding of PSMA PET next year. A recommendation has just gone to government to say the evidence is in, you should fund this test. Not only does it improve outcomes and it's more accurate, but it also won't cost any more. In the USA, we now have 2 FDA-approved radiotracers, gallium PSMA-11 and DCF-PYL. And some people are using other tracers like PSMA-1007 and more to come. And the head of the Prostate Cancer Foundation said game changer is almost an understatement of how prostate patient care can be improved by this technique. Now we're going to change from imaging to therapy, theranostics. The audience will be well familiar with this concept. The first compassionate access treatments, again, were done in Germany by the Munich group, Heidelberg group, and others. And we got on board designing a prospective phase 2 study early on, And initially we recruited 30 men, and that was expanded to a 50-patient cohort. And we took men who had failed all forms of treatment. That's chemotherapy such as docetaxel and carbazitaxel, and hormone treatments like enzalutamide or abiraterone. And we saw remarkable responses. In fact, a PSA reduction of 50% or more in 64% of men. This is really unprecedented for a third, fourth line treatment. And the results of this study led directly to Novartis purchasing PSMA 617, and also the therapy and the vision trial that we're going to come and talk about now. Because again, our oncology colleagues, they're impressed by this data, but they don't see it as practice changing. Again, they say we need a randomized trial showing improved survival, improved quality of life compared to existing treatment options. This is an image of the year from 2018 resulting from that trial, showing us how nicely PSMA PET is able to visualize the extent of prostate cancer. Here we see images before and after treatment in the 8 best responders in that research. Truly remarkable responses, but we should keep in mind that all 50 men, prostate cancer eventually recurred. So this is by no means a curative intent therapy, and in that way it is a palliative, but as we'll come to see, life-prolonging treatment. So we now have 2 randomized controlled trials of lutetium PSMA 617. The therapy trial that I had the pleasure of leading, and again an Australian multi-centre trial running at that pro-PSMA network of sites plus a few additional sites, and the industry-sponsored phase 3 vision trial. So let's start with the therapy trial. In this trial, we took men who had progressed after docetaxel and mostly after novel anti-androgen therapy, and we screened them with a PSMA and FDG PET. And we excluded around 30% of patients, a little less than 1/3, by virtue of either low PSMA expression at all sites of disease that we can see on the left, or patients who had some sites of PSMA highly expressing disease, but other sites of FDG positive PSMA negative disease, such as the liver in this patient. We found 200 eligible men. Important to note that FDG positivity is not an exclusion criteria. We can see patients on the left with very high metabolic activity at all sites, but concordant high PSMA uptake. These patients are highly suitable for therapy. And also patients that are PSMA positive, FDG negative. And they were randomized to either carbazitaxel chemotherapy, an accepted life-prolonging therapy, or 6 cycles of lutetium PSMA 617. The primary endpoint of this phase 2 study was a PSA reduction over 50%. And this occurred in 66% of men randomized to lutetium, compared to only 37% of men randomized to carbazitaxel. These waterfall plots showing this large difference between the 2 arms, each bar representing the best PSA response in each individual patient in each arm. We also showed an improvement in progression-free survival with a hazard ratio of 0.63, which by oncologic standards is quite impressive. By 12 months, almost everyone randomized to carbazitaxel had progressed, whereas around 20% of patients who received lutetium PSMA 617 remained without progression. So quite a big difference at that 12-month time point. We don't have overall survival data from the therapy study yet. We will run that analysis at the end of this year and hope to present it early next year. We also looked at RESIST objective response rates. This was on CT, not PSMA PET. 49% with lutetium PSMA compared to only 24% with chemotherapy. And now we come to the phase 3 vision trial. This is the Novartis trial, a very large study performed at over 50 centres in the US, Canada, Europe. And in this study, over 800 men were randomized to lutetium PSMA 617, again 6 cycles every 6 weeks, plus protocol-defined standard of care versus the protocol-defined standard of care alone. And it's important to note that protocol permitted did not allow things like chemotherapy, immunotherapy, radium-223. So it was really almost second or third line hormone crossover treatment, steroids, radiation, treatments, palliative treatments like that. And this study in all 831 patients did show a significant improvement in overall survival. Median survival of 15.3 months compared to 11.3 months. And this is now being evaluated by the US FDA with a view for registration and reimbursement. And this is expected to occur next year. What about side effects? Well, lutetium PSMA is really a well-tolerated targeted treatment. This table shows us the toxicities defined in the vision and therapy trials, probably the best data we have available to date. And the main side effects being dry mouth in 40 to 60%, but only grade 1 and 2. We're not seeing grade 3 or 4 severe dry mouth. And also nausea. And this is due to the small bowel radiation and probably a little underestimated prior to these randomized studies, but we do see a significant amount of nausea, in fact, similar to the carboxytaxel chemotherapy. Hematotoxicity, as shown here, we do see some grade 3 or 4 thrombocytopenia in around 10% and grade 3 to 4 anemia also in a small number of patients, around 10%. Importantly, in both these randomized trials, they embedded patient-reported outcomes. And this is really critical because there's only two things that matter with treatments as a third or fourth line treatment option. Does it prolong survival? And does it improve quality of life? And lutetium PSMA does both, which is fantastic. Here we can see the FACT-P total scores from the vision trial over time, and a really huge difference between the two arms. Median, time to worsening of 9.7 months with lutetium compared to only 2.4 months in the control arm. And pain, 14.3 compared to 3 months. Huge difference. And this is something we note clinically. Men typically have spread to bones that causes bony metastatic disease, pain, and lutetium PSMA is very effective at reducing pain. Many patients being able to stop their opiate analgesics and experiencing improved quality of life. We also looked at patient-reported outcomes in the therapy study, and here we can see the results, and we don't get any of those nasty chemotherapy side effects such as skin rash, sore hands and feet, hair loss, altered taste, diarrhea, and really every parameter favouring lutetium in this trial. But we're not curing men, so there is a need to do better. And how can we do better? A median survival of 15 months. It sounds not so great to a patient in this situation. They want to live really many, many more years. And it begs the question, how can we do even better? And in this review article, we go through some methods where we may be able to achieve that. So let's go through some of these, and we'll start with PET imaging, which, as I've alluded to, is critical for optimal personalization and patient selection. 66-year-old with metastatic castration-resistant prostate cancer after docetaxel and enzalutamide, bony metastases, SUV max 22. In the therapy trial, we said you had to have an SUV max over 20, tick. In the vision trial over liver, clearly tick. So by PSMA PET criteria, clearly suitable for both trials. But in the therapy trial, we additionally did an FDG PET. This is performed 1 day later, and look at the images, a striking difference. Let's deep dive a little bit further. Color coding this just enables us to visualize how much greater in volume the FDG PET disease is in this patient. By overlapping the images, we can see that less than half the disease is potentially targetable because half the disease is FDG positive, PSMA negative. And we can't target that. Let's have a look at this in more detail. This is one of the vertebral metastases, almost no uptake on the PSMA, high uptake on the FDG, and invisible on the CT. So this is a patient that we would direct away from lutetium PSMA. We would send this patient back to their treating oncologists. What else can you offer this patient? Because I don't think lutetium PSMA is going to be beneficial. The other role of PSMA and FDG PET is as potential predictive or prognostic biomarkers. And we looked at this in the first 50 patients we treated. Justin Ferdinand, a visiting medical student at the time who's now undertaking oncology training in Germany, and we showed that the volume of FDG avid disease was predictive, or prognostic rather, for overall survival, and patients with higher uptake on the PSMA PET defined by an SUV mean using a whole body tumour contour also had improved survival. So increased uptake, higher delivery of lutetium to sites of disease, better outcomes. And this parameter, the SUV mean, was recently incorporated into a 270 multi-patient normogram study together with my UCLA, UCSF and German colleagues, and we were able to show that the tumour SUV mean in this population correlates with overall survival, also radiographic progression-free survival and probability of PSA response. And I hope that these quantitative PET parameters will increasingly be used to select and optimize patient management. Let's move on to dosimetry. And why do we need dosimetry? Well, I've got to say, when I finished nuclear medicine training, I didn't actually know that much about dosimetry. And when I arrived at Peter Mac, I met another Canadian, Jean-Mathieu Burgat, who would be well known to this audience, and he taught me a lot about dosimetry, and he set up a quantitative SPECT-CT protocol that we still use today in our centre. So why do we need dosimetry? I think it's critically important when we have a new tracer for safety, validation, efficacy, like we did in our Lancet cohort initial 30 patient study. Can potentially use it to individualize the administered activity. This is something Jean-Mathieu does very well and is exploring. Potentially it can be used as a prognostic biomarker, and in some jurisdictions it's a regulatory requirement. Now this is how dosimetry has been performed in the past. Multiple 2D planar images, manual regions of interest around normal organs, very time consuming planar MERD dosimetry, and no one really likes this. It's labor intensive. No one really understands what to do with these results. This is the way we do dosimetry on the left. We use 3 time point quantitative SPECT-CT, or now this can be done with a single SPECT-CT image, and from that we can generate these whole body maps of radiation distribution and dose. So we can see the kidneys with blue around them having very low dose, same with the salivary glands, and high doses in tumour. We can see the adrenal glands in this patient received over 50 gray. And what we showed from our initial study was that dose correlated with outcome. If we took the mean dose to all of tumour, so that's like the SUV mean equivalent around that red area around tumour, if we got less than 10 gray using 3 time point dosimetry to tumour, there were 10 non-responders and only 1 responder. And you can see a clear separation between higher dose patients very likely to have a PSA reduction over 50%. So lutetium PSMA, it's not a magical therapy. We're just delivering radiation to sites of tumour, and if we can do that efficiently, we get good responses. We were also able to show that the SUV mean on a PSMA PET scan correlates with the dose to tumour using SPECT-CT. That's the graph on the left. Quite a nice correlation. So in summary, the intensity of uptake correlates with both dose to tumour and response. And now, if we want to look at normal organ dosimetry, we can do this very quickly. This is work from Price Jackson, our medical physicist, and an AI algorithm has contoured the kidneys in these 30 patients. The computer can do this extremely quickly, and when we compared human contours done manually to the automated neural network, the results being very similar. So as these automated methods evolve, I think we're going to see hopefully a lot more use of dosimetry. Now, a post-therapy SPECT image alone without the fancy dosimetry is also extremely useful. In this patient, we can see an impressive response after the second cycle of lutetium PSMA. And on the basis of that, and also a 95% reduction in PSA at the time, we paused treatment. We didn't give a third cycle. We said there's not a lot of target left. And when we repeated the PET scan 3 months later, we saw a complete response with a 99% reduction in PSA. Now, this patient wasn't cured. Several months later, around 9 months later in this patient, there was recurrence, and then we proceeded with cycle 3, 4, 5, etc. But we didn't use up all 6 cycles initially. And our therapy randomized trial actually incorporated this philosophy probably the first time this has been done in a randomized controlled study, and around 1 in 10 patients, we paused early, they remained on trial, and then we just continued cycles of lutetium at time of progression. Now, another way to improve treatment is to combine it with drugs that our medical oncologists use. And these can broadly be done in 3 categories. 1, radiosensitizers to enhance DNA damage from radiation. 2, drugs that upregulate the target, a little bit like using BRAF or MEK inhibitors in thyroid cancer to upregulate the sodium iodine syn-porter, or immunotherapy, because there's good data or interesting data showing that the combination of immunotherapy and radiation may be synergistic. And in order to study this, we've established the Prostate Cancer Theranostics and Imaging Center of Excellence, or PROSTIC, at Peter Mac. This is thanks to a large grant from the US-based Prostate Cancer Foundation, and it has 3 main aims: to increase the number of clinical trials that we're running at Peter Mac, to do some discovery research, and to provide some education and leadership. So I'm going to focus on a few of the clinical trials that we're now doing at Peter Mac, and it leads us to another Canadian, Dr. James Buteau, who's currently our PROSTIC Fellow and really engaged in writing clinical trials protocols and helping us run a large number of trials. So here's a list of all the trials, and the focus has been on taking lutetium PSMA from a last line of therapy, when you've failed everything and you have nothing left off, to a first line of therapy. And I don't have time to go through each of these trials today, but we'll focus on a few of them. But first, I just want to highlight that there's many more trials being done, US, Canada, and Europe now. Lots of trials, more than 10 in the second line therapy setting. So it's just the beginning for lutetium PSMA. And if we move back earlier, we have trials open in the castrate sensitive setting, even in the first line setting. So let's look at a couple of these trials that we're running at Peter Mac. One is the upfront PSMA trial. In this trial, we're taking men with newly diagnosed high volume metastatic disease, and they're having a PSMA FDG PET, and then being randomized to either standard of care, which is ADT plus docetaxel, or the experimental arm, 2 cycles of lutetium followed by the standard of care, being the docetaxel, with ADT running throughout. The primary endpoint being an undetectable PSA at 12 months. This is a phase 2 trial, 140 patients. Just yesterday, we randomized patient number 70, so we're halfway through this trial, which is really pleasing. And then this trial, the lutectomy trial, where we're taking men with newly diagnosed high-risk prostate cancer, with or without pelvic nodal disease, but without distant metastatic disease, if they have high uptake on PSMA PET, which we define by an SUV max over 20, we're giving them 1 or 2 cycles of lutetium PSMA 617 prior to proceeding to a standard of care prostatectomy and pelvic nodal dissection. The primary endpoint of this study being absorbed radiation dose. How much radiation can we get to that prostate, primary, or lymph nodes? And secondary endpoints as listed. So a really radically new way to treat men with newly diagnosed prostate cancer. And the hope here is, could lutetium PSMA 617 therapy, could it replace surgery? Could it replace external beam radiotherapy in this primary setting? Or can it be beneficial as an adjunct in addition to surgery or in addition to radiation? And in this trial, we're really trying to show safety and dosimetry, and hopefully this, if successful, it'll lead to larger trials trying to prove these benefits. Here's Professor Declan Murphy, our urologist, head of the GU oncology team, proudly holding a prostate after a prostatectomy in a patient who received lutetium. And what he's already noted, because we have done over half this cohort already, is that the surgical field is clean. Unlike external beam radiation, where you get a lot of fibrosis, it makes surgery difficult. That 1 millimeter path length of lutetium means that his surgery has a clean field. It's to him, doesn't even seem that the patients had any radiation. Now, in order to do better, we can also use newer isotopes, alpha emitters, Auger emitters, or change ligands, maybe antibodies, mini-bodies, next generation ligands. But we don't have time to talk about that today. And I'm going to leave that to our next speaker, Professor Rod Hicks from Peter Mac, who'll deep dive into the future of theranostics. So with that, I'd like to thank all the investigators around Australia. We've got this great network of nuclear medicine physicians working closely with medical oncologists, urologists, radiation oncologists, and our clinical trials staff. The whole nuclear medicine team at Peter Mac are chemists, pharmacists, technologists, nurses. The GU oncology team at Peter Mac are funding partners. And in particular, what month is it? It's November. So we've got to do a shout out to Movember, who fund a lot of our research. And if you're feeling like if you're in a generous mood, follow that link and give to our campaign. Some of you might not know, Movember was founded in Melbourne, Australia. It's now gone global, and they're doing a great job in, funding research not only at our centre but all around the world to improve outcomes for men with prostate cancer. So I really like to thank everyone and hope we can see you in person. Thank you. Bye-bye.